I want to welcome all of our participants to today's Antimicrobial Stewardship webinar, titled Improving the Antibiotic Stewardship Value of Microbiology Tests with Dr. Romney Humphries. I am Marnie Peterson, and I am the Outreach Coordinator for the Antimicrobial Stewardship Project, which was created by the Center for Infectious Disease Research and Policy at the University of Minnesota to provide current comprehensive information on the topic of antimicrobial stewardship. Before Dr. Humphrey begins her webinar today, and we're all very excited that she's joined us today, a brief background about her. She's recently joined Accelerate Diagnostics as their Chief Scientific Officer. Before joining Accelerate, Dr. Humphries was the Section Chief for Clinical Microbiology at UCLA Medical Center and an Assistant Clinical Professor in the Department of Pathology and Laboratory Medicine at UCLA School of Medicine. She serves on several committees and working groups for organizations including the American Society for Microbiology, the Clinical Laboratory Standards Institute Antimicrobial Susceptibility Testing Subcommittee, the U.S. Food and Drug Administration, and the World Health Organization. Dr. Humphries obtained her PhD in microbiology at University of Calgary and completed a clinical microbiology fellowship at UCLA. For our participants, we welcome your ability to engage and your questions with Dr. Humphries. So at any time during the webinar, if you look at the lower right-hand corner of your screen, you'll see a chat box. We encourage you there to submit your questions or comments to Dr. Humphries at any time during the webinar, and she will address them at the end by typing in the question and just submitting it to all panelists. So just a reminder that the webinar is recorded and all lines are muted during the webinar. So please submit those questions via the chat box. Well, with that, I'd like to welcome Dr. Humphries to present her webinar to us today.
Thank you so much, Marnie. I'm very excited to be here virtually and to present some thoughts on how to improve our antibiotic stewardship value for the microbiology lab tests. As Marnie indicated, my background is really as a clinical microbiologist and is running the lab, and I think that there's an awful lot of opportunity to help improve stewardship that maybe is not always fully utilized from the lab perspective. And so we'll talk about some of these. So the objectives for today's webinar are to evaluate how the lab can support antimicrobial stewardship. We're going to talk a little bit about the antibiogram, some of the basics, which hopefully everybody is familiar with, but also some of the pitfalls, and talk a little bit about how we can enhance our antibiograms, as well as how we can use rapid diagnostics, and a lot about how we can report more effectively. So if we take a look at the microbiology lab, in my somewhat biased perspective, of course, I do think that what the lab provides is really integral to stewardship programs. And this really, in my mind, comes into three buckets. So one would be testing, and we'll talk a little bit about this concept of microbiology stewardship and how that can help with our antibiotic stewardship endeavors, sort of in an out-of-sight, out-of-mind sort of approach. We'll also talk a little bit about the types of routine susceptibility testing that the lab can do to help support stewardship, as well as the role of rapid diagnostics and how to best implement those effectively. Of course, the microbiology lab also has an awful lot of data that we generate, and this data can be very powerful in informing both our antibiogram to look at empirical therapy decisions, but also take a look at some of the resistance trends that we might be seeing at our individual institutions, or in some cases, if we broaden the antibiogram into regions or even entire states. And then finally, from a reporting perspective, I think that there's quite a lot that can be done in that regard. Many labs, report as tested, but there's a way to harness the data a little bit more effectively through either selectively reporting things or to generate reports that are a little bit more informative. So let's touch on this first concept of stewardship for the microbiology lab, and this is something that I'm very pleased to see is happening with some more frequency. And obviously, this seems obvious So you would only perform a test if there was a clinical indication for that test. So, for example, if the patient doesn't have symptoms, why would you test them for the disease? If you're not really going to use the results, no value in testing. And a lot has to do with this pre-test probability and the likelihood of a false positive or false negative result. But how the lab can help really reinforce this is to develop some pretty strict rejection criteria to ensure high quality specimens. And I know this makes people cringe a little bit because you certainly don't want to be the lab police, much like stewardship programs don't really like to be the antibiotic police. But we can really, I think, provide a lot of value even with simply doing some interesting things with our IT systems and how people place orders. We also would want to reject requests from our clinicians that ask us to report everything that grows. I often said, you know, it may be helpful to know what your patient's normal flora is, but clinically it's not going to be all that actionable. And to use susceptibility testing, or AST, on isolates that are clinically significant only. So let's go through an example case, and I love this case. It was something published by Nancy Miller in the Clinical Microbiology newsletter. And a 55-year-old woman with an ulcerating infection of her right breast. And so she presents to her outpatient practitioner. They perform a surface swab, which microbiologists hate hearing that, a swab of the ulcerating wound. And from this grew E. coli, Pseudomonas aeruginosa, as well as some coagulase negative staph. And so they treated the gram-negative rods. Unfortunately, this woman had no improvement. She came back for visit 2, same story, treated again. Visit 3, treated a third time, no improvement. And then finally, they collected the right specimen, which would be a biopsy, and pathology identified that this patient actually had an infiltrating ductal carcinoma with a superficial colonization of E. coli and Pseudomonas. So they were really treating the wrong thing in this case, and it really related back to the type of diagnostic testing as well as specimen that was collected. So here's an opportunity that going right to the source would have led to a much more favorable both patient management, but also outcome. Another great example is our Clostridium difficile testing. And I know we're all just, distraught at how to best handle Clostridium difficile. There's a lot of discussion out there that the molecular tests are overly sensitive and are identifying colonization. And so, how to approach that today, knowing that we don't have good tests for the toxin itself, is to make sure that the right patients are being tested for Clostridium difficile. And so this is a great study at Stanford, my colleague Naz and I put together, where they took a look at real-time electronic tracking of diarrheal episodes as well as laxative therapy to look for whether or not a test for C. difficile would be honored. And so essentially in this scenario, their hospital information system automatically flagged patients who were either on a laxative or who had fewer than 3 unformed stools in a 24-hour period and did not test or rejected those tests when placed for C. difficile. And so they saw a tremendous reduction in the number of tests that were performed, as well as the incidence of hospital onset C. difficile infection, which of course makes our administrators very happy with all of the reporting we're required to do. But importantly, from a stewardship perspective, significantly reduced the amount of oral vancomycin therapy being used per 1,000 patient days. And so again, just by simply looking at testing and making sure the test is being performed on the right patient, you can affect these. And when I was at UCLA, we started to get quite creative about this type of approach. A good example is our respiratory virus panel. We renamed to be the Special Immunocompromised Respiratory Viral Analysis Test. And what that did was significantly reduce the number of outpatients or, mildly ill people that were getting a fancy, expensive molecular respiratory virus test done. I will say in all of these examples, there are, of course, always exceptions to the rules, and how we dealt with those at UCLA, it was simply a conversation with the microbiology lab director. Okay, so moving on from that kind of concept, let's talk a little bit about the antibiogram, and hopefully this is something that everybody is familiar with. And most times, the antibiogram is listed as simply, a laundry list of the common bacteria that you would expect to see in patients and the percent of them that were susceptible to various antimicrobials. And the primary uses of this are to guide empiric therapy as well as to monitor trends. And so all labs, and it is a requirement, generate an antibiogram at least annually. And I think most physicians have no idea what to do with it, and so it's something that gets kind of looked at, oh, that's interesting, and then put away in, maybe the office desk, or if you're lucky, in the lab coat pocket, and not thought about all that often going forward. Just a comment, there are guidelines from the Clinical and Laboratory Standards Institute, CLSI, on how to generate an antibiogram appropriately. This is in the M39 document. Your lab will have access to this, so you can ask them if you haven't seen it before. But essentially, it plays out the basic things that you need to consider in order to generate an antibiogram that is generating valuable and correct information. One thing I wanted to talk about briefly is one of those requirements is that you only include the first isolate per patient per year in your antibiogram. And the reason for that is you would hate for the one patient who has the very resistant ventilator, associated pneumonia caused by a Acinetobacter that's resistant to everything and who's been cultured, every couple of days to skew your data tremendously, because that may make it seem as though you have a much bigger resistance problem. The reality is that this elimination of duplicates can have a pretty small impact on the percent susceptible, but also a pretty big one, depending on the type of organism and drug you're talking about. And so here's two examples from our old UCLA data, where we looked at, on the left, Klebsiella pneumoniae and ceftriaxone susceptibility in 2016. And you can see, if you looked at all isolates, it was 82% susceptible. If you looked at just one isolate per year, it was 89. And if you looked at one per 30 days, it was 88, and one per patient per change in susceptibility profile. So that allowed us to capture those patients who were developing resistance while on therapy. It went to 87. So, not probably even statistically significant differences given the number of isolates that we were looking at. However, if you look at organisms like Pseudomonas aeruginosa that has a tendency to change its antimicrobial susceptibility profile while on therapy, and a great example would be imipenem susceptibility, right? It quits expressing that porin, and all of a sudden you're resistant. This can make a pretty tremendous change to the antibiogram by 10% or more. And so if we looked at all of our Pseudomonas, it was 68% susceptible to imipenem. If we looked at just one per patient per year, it was 79, so almost 80%. So a fairly big difference there. All right. The other thing just to caution people about with the antibiogram is the concerns about using or generating antibiogram data when you have a very small number of isolates actually tested. And this comes up a lot. And here's a good example of it, where we had a very unfortunate case of a baby dying postpartum sepsis, and due to an E. coli that was resistant to ampicillin. And so our infection control group wanted us to take a look at how often are E. coli isolated from babies in the NICU susceptible to ampicillin. And the reality was we only had 4 such isolates in the prior year. And so if you take a look at the 95% confidence interval around that data, while it's 50% susceptible, the 95% confidence interval is 9 to 90. So that piece of information is pretty much meaningless. In contrast, if we looked at all E. coli isolated that year, we had 51% susceptible, and the confidence interval was much tighter. And so, this is important in 2 ways. First, of course, is when you're trying to use this kind of data to inform clinical, treatment pathways, but also when you're trying to evaluate trends year to year. And, the smaller the number of isolates, the bigger the change needs to be for it to be significant. The final caveat to antibiogram data that I'll point out is the limitations to the data. And, while I think we all hope and wish that our microbiology labs were cranking out absolutely bomb-proof data that was very, very good, the reality is this is just not the case, even in large, sophisticated labs. So, for example, perhaps there's testing biases, and we'll talk about an example of that in the next slide. Or perhaps there's issues with the susceptibility test system your lab is using, and so it may not be able to accurately determine an MIC for a given antimicrobial, or maybe they're not using the most up-to-date CLSI breakpoints. So these types of caveats to the data can really affect what you're seeing on your antibiogram. So here's just a classic example of how the simple ordering practices can truly affect your antibiogram data. And so this is a survey of Irish physicians. It was published a while ago in JAC, where they queried them on whether or not they would do a culture and susceptibility test for patients suspected of having a urinary tract infection. And so I don't think it should be too surprising that if it was, a young, otherwise healthy woman who had a probable uncomplicated UTI, only 59% of them would order culture and susceptibility testing. And in fact, our guidelines say you probably don't even need to do that at all, as compared to a woman who had a previous treatment failure where 90% of them would have ordered a culture and susceptibility. And of course, this latter group is the one that's much more likely to have resistant organisms. And so the data on the cumulative antibiogram does not really represent your patients with uncomplicated UTIs. It represents your patients with more complicated or problematic UTIs. And so, if you want to use your antibiogram to give guidance to your community physicians on what drugs to use, that's probably not the best use of those data. Here's another example to do with limitations to the test system. And so here we have an Enterobacter aerogenes. And what we noticed, and this is again data from UCLA, was when we were testing Enterobacter aerogenes on our antibiogram, our imipenem susceptibility was quite a bit lower than our meropenem or ertapenem. And this was puzzling to us because Enterobacter is not necessarily one of the isolates that you would expect to have less susceptibility to imipenem, like your Proteus, Providentia, Morganella group. And so when we parsed this data out and looked at urine-only versus non-urine, you can see that this effect was much more evident in the urine specimens. And so, of course, our lab used a commercial system to test urine isolates because of how many we got, whereas we used reference broth microdilution to test isolates from other sources. And so when we investigated that commercial system, what we found is 18 of the 20 isolates that were called resistant by this commercial system were in fact susceptible by the reference broth microdilution. And so this system was overcalling resistance in Enterobacter aerogenes. And so our lab policy would be to not report imipenem routinely, and the good news is that it was not on formulary, so it wasn't such an issue. And then if somebody phoned to ask for it, we would report susceptible results and we would confirm any resistant. So this type of investigation, I can tell you, happens all the time in the lab, and again, just speaks to sometimes the automated systems, as good as they are, sometimes do have their unique issues. Another kind of great example of limitations to the data, and this is one that's very near and dear to my heart, is this whole issue of the breakpoints that the lab is using. And so we know, as a background, many of the beta-lactam breakpoints for the Enterobacteriaceae, but also Acinetobacter and Pseudomonas, have been updated since 2010 by CLSI and the Food and Drug Administration. The problem with this is many of the commercial systems have not updated their breakpoints and gotten them cleared by FDA. And so if you were to buy one of these systems in the lab, the out-of-box software would be with the pre-2010 breakpoints, which, honestly, are almost a decade out of date. And labs have the ability to change these, but it is difficult, and it renders the test to be off-label. And so there are some labs and institutions that actually have policies against doing off-label lab testing. And so in many cases, labs will wait for the commercial manufacturers to update their breakpoints and have them cleared by FDA before they make these changes. And this is really unfortunate. We did a survey in California to get a sense of what was happening. And this data is available online from CID now. And so when we surveyed labs across the entire state, what we found was 28% of labs were using the old breakpoints. And this doesn't seem like that big of a number until you consider the fact that some of the very large labs that were doing a lot of the testing fell into this 28%. And even more problematic is in those 28% of labs that were using the old carbapenem breakpoints, about 40% of them were not doing any kind of confirmatory carbapenemase testing, which was the old recommendations from CLSI. So not only were they not using the right breakpoints, but they weren't even doing the safety catch of a carbapenemase test. And this is really problematic. We looked at our data at UCLA. We had a large collection of carbapenem-resistant Enterobacteriaceae, and we looked at those that produced a carbapenemase, and we evaluated how many of them would be called susceptible by the old breakpoint versus by the current. And what you can see is, in particular for imipenem and meropenem, 20% of isolates that have a KPC will be called susceptible by those old breakpoints. That's a pretty big number. And so I think we are, in fact, missing quite a bit of really clinically important resistance. And again, that would be reflected in your antibiogram. And this is pretty scary, the impact of these delays, it can be underemphasized. This is data from Orange County in California, where they used a computer simulation to estimate what a 5-year delay in implementing breakpoints would be. And in this one county in Southern California, they estimated it would result in an additional 8,500 more patients that were colonized with these carbapenem-resistant Enterobacteriaceae. And, we're much further out than 5 years at this point. We're at, 9 years since these breakpoints were changed. And this effect in this particular county was most apparent in the nursing home populations. And the reason being, of course, these patients aren't put under contact precautions because their colonization status is not recognized, or their infections aren't recognized as being epidemiological concern. So you may be thinking, well, I know my lab maybe doesn't use the most up-to-date breakpoints, but we do a carbapenemase test, and we do the modified Hodge. And unfortunately, or probably fortunately, if you look at it from my perspective, the modified Hodge test is on its way out. In 2018, CLSI is striking that as a reference method to detect carbapenemase. And this slide really nicely summarizes the major problem with the modified Hodge test, which is you wind up with a very high incidence of false positive results, 37%. And this is mostly due to your Enterobacters, Siderobacters, and even organisms like E. coli. The modified Hodge was really designed to look at Klebsiella pneumoniae that express the KPC gene. And so it works okay for those organisms, but not so much other isolates. And so in this case, you're overcalling carbapenem resistance in these isolates. All right, so now that we kind of have a sense of some of the limitations to our antibiogram, let's talk about some ways that we can get creative with the data when we know what we're dealing with. And so there's a lot of specific questions that can be answered, including segregating that antibiogram into locations, outpatient versus inpatient, which we did routinely, perhaps ICU, maybe SICU, PICU, whatever, your area of concern is. The specimen type, so a urine antibiogram versus a blood antibiogram. I would say, at the very least, splitting the urines out is a good idea, knowing that the vast majority of microbiology testing done in the clinical lab is urine cultures. And so if you're not pulling those out, your antibiogram probably really just reflects the urine pathogens as the majority item. The clinical condition, so perhaps you want to have an antibiogram for your CF patients, your burn patients, or patient age. You can also look at resistance profiles, susceptibility for combinations of drugs, and we'll talk about examples of that, and groups of organisms. So here's an example, and this is a little bit complex, but I'll walk us through it, on where we took a look at what agents we would recommend for our emergency department to use as empirical therapy for urine isolates. And so we know the IDSA current recommendations are Cipro or Trimsulfa, depending on the clinical scenario and depending on your resistance rates. And so you can see here data from UCLA. If you look at just all isolates, things don't look so great, whereas if you start splitting things out into outpatient versus younger women, you can start to get some of your treatments back. And so that's one way to look at the data. In a bit more detailed, we took a look at our isolates from the emergency department, and this is 579 isolates of E. coli isolated from urine in the emergency department in 2016. And so if we took a look at resistance rates among these E. coli, and to be honest, in the LA area, we have a big fluoroquinolone resistance issue. We have a pretty big Bactrim, that's SXT, resistance issue. And so historically, we used to use an oral cephalosporin, and that was predicted by Cefazolin. Cefazolin breakpoints changed in 2010, and as a result, most of our isolates were now, well above that threshold that we would feel comfortable in using an oral cephalosporin to use empirically. And just to clarify, that Cefazolin result was being used to predict the activity of the oral cephalosporin, and I'll talk about that in a moment. Nitrofurantoin looked pretty good, but unfortunately, most of our patients that came in through the ED were elderly, and we just didn't feel comfortable about that as a drug choice for, I think, obvious reasons. And so, when we took a look at changing breakpoints, here's an instance where this has an unintended negative consequence. And so you can see in dark blue here, among our isolates with the new breakpoint, we see a pretty significant reduction in percent susceptibility, in particular for Proteus mirabilis. Now, this Cefazolin breakpoint that was revised is really intended for systemic use. And what we're doing here is something where we have the drug concentrating in the urine, and probably a urine breakpoint would be more appropriate to assess the efficaciousness of this drug. So that's exactly what CLSI did. We developed a breakpoint, which is for use only for uncomplicated urinary tract infections, and it's simply testing Cefazolin. There's both DISC, and I'm showing you the MIC breakpoints here. And what we found, looking through a lot of data, was that the Cefazolin predicted the activity of oral agents, including cefaclor, cefdinir, cefpodoxime, et cetera, when used for therapy of uncomplicated UTIs for E. coli, Kleb, and Proteus mirabilis, your non-ANT-C producing organisms. And so when we applied this breakpoint to our data, all of a sudden the oral cephalosporins again became a treatment option, and that is what we continue to recommend for emergency department urinary tract infections. This is, of course, complicated because when we started this, we would report Cefazolin, and we had a footnote that said Cefazolin predicts the activity of blah, 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 all the oral cephalosporins that were on formulary. And I can tell you absolutely nobody understood what that meant at all. And so what we wound up doing is changing the name on the report. So instead of reporting Cefazolin susceptible or resistant, we reported oral cephalosporins susceptible or resistant with a footnote that referred to which oral cephalosporins were on formulary and which organisms and the indication for uncomplicated urinary tract infections. And so that worked out really quite well. The challenge for implementing this in other labs is the commercial systems, of course. And so there are some, again, limitations here. So most of these systems are not FDA cleared for the breakpoint for Cefazolin for systemic use. And I can tell you none of them will ever seek this clearance. And the reasons for that is the new Cefazolin breakpoint bisects the wild type population, which makes it really difficult, if not impossible, to get the test cleared. And many of the panels, as a result, don't even have dilutions low enough to test these systemic breakpoints. But what you could use these cefazolin drugs on these panels for is this urine indication, because they have the concentrations they can test, and so that's a good approach to keep using this as an option. And so here's an example of our report. I realize it's kind of small. That's the unfortunate thing about comments on reports. It is small, and I think a lot of the time people ignore it, but you can see in the drug listing we have oral cephalosporins, and then we have in the footnote, which I've highlighted in pink, what drugs are included in that. And we actually use this type of reporting comment an awful lot at UCLA. So we had comments about what to do with the susceptible dose dependent for cefepime. We had comments on what to do if we detected KTC in isolates, and so I'll just read that comment because, again, I know it's small, which was this organism is positive for the KPC carbapenemase. Infectious diseases consult strongly recommended, and this patient requires contact precautions, and we referred to the policy that they should look at. If we isolated Candida glabrata, we talked a bit about calling Stewardship for help on that. If we isolated MSSA from blood, we talked about that organism's susceptibility and about how vancomycin is inferior for serious infections. And we also had comments about if we isolated coagulase negative staph from blood, how that's most likely just a contaminant and doesn't warrant therapy. And so these comments were all developed in conjunction with our stewardship team. In some cases, we referred people to phone the stewardship team for these things. Sometimes we had them phone the lab for further information, but I think overall it did help quite a bit. All right, so I know that many of us are implementing rapid diagnostics into the lab, and I think that there's a real opportunity to partner a rapid diagnostic with the antibiogram data. So let's walk through some of the options for that. So, you know, typically when we isolate organisms from the blood, the lab phones the patient care area. So, for example, in the ICU, and they say, hey, we isolated gram-negative rods from the blood of your patient. And we currently have in our antibiogram a breakdown of what organisms were isolated from blood. So you can see the breakdown here in the pie chart. Most of them are E. coli and Klebs, not surprisingly. But, you know, 11% are Pseudomonas. And you can also take a look at things like the antibiogram for all gram-negative rods in both your hospital from blood or perhaps from the ICU from blood. And you can see, looking at this antibiogram, it's kind of depressing because nothing really jumps out at you as a really great beta-lactam kind of backbone to your therapy that you might pick. And so let's say, for example, you do a rapid gram-negative rod identification test. So, for example, a BioFire or other similar types. And in this case, rather than phoning to say, hey, your patient has gram-negative rods in your blood, we can phone and say, hey, it's E. coli. And in this case, things look a lot better. You can see very high percent susceptibility to, you know, the carbapenems, obviously, but cefepime as well. Even piptazo doesn't look all that bad. Now, so that's great if it's an E. coli. And again, this is a breakdown of blood isolates. But what about if we phone and say it's a Pseudomonas aeruginosa or a Klebsiella pneumoniae? Again, you're not left with a whole lot of options. One approach for, in particular, Pseudomonas aeruginosa, and we've started doing this for CRE as well as for Stenotrophomonas, because I'm not sure about you, but at our institution we were seeing an awful lot more steno than we had in the past, is this combination antibiogram. And so what this is really just a cross table of the type of drugs that you might combine to treat or cover a Pseudomonas aeruginosa. And so in the example here, we have cefepime as the first row. In brackets is 81, so that's the percent of isolates that were susceptible to cefepime. On the first column, we have amikacin at 97% susceptible. And then in between those two, that 97 with the 3 superscript, that refers to the percentage of isolates that were susceptible to either amikacin or cefepime, so one of the two in the combination. And this can be helpful when you're trying to figure out what the best combo might be to cover this potential Pseudomonas aeruginosa or known Pseudomonas aeruginosa if the lab has a rapid ID method. So again, like I said, what if it's a Klebsiella pneumoniae? And again, here you can see that things don't look all that great for our Kleb pneumos. I will highlight the fact that we did have an outbreak of CRE at UCLA in 2015, and so a lot of these numbers are slightly skewed by that. Nonetheless, those were our real data, and I think at the time we did not have a good sense of who was affected by the outbreak or not, so Kleb pneumo in the blood was kind of a scary thing. And so one way to approach this is many systems nowadays, both the BioFire and the Veregene, look for some gram-negative resistance markers. And so in this example, what one could do is split out the isolates for those that do not have a carbapenemase, which you can see here, or those that do have a carbapenemase. And things change quite a bit based on whether or not that KPC was detected. The caveat to this, I will say, is that antibiotic resistance is changing quite a lot. And so, systems that just look for KPC probably aren't broad enough. We saw an awful lot of non-KPC carbapenemase producers at UCLA, including the isolate that caused our outbreak. It was an OXA 232 producer. Also, it's not just carbapenemases that cause this type of resistance. And so a good example is, you can look, and the ertapenem and meropenem are not at 100%. And so this is something, again, due to probably plasmid AMP-C and loss of porins that can lead to these very resistant phenotypes. Nonetheless, it still gives you a better sense of where you stand with that individual patient. So I think a lot of us have started thinking about doing an antibiogram for things like CRE. And so here is what ours looks like. You test drugs that are routinely done by the lab, the aminoglycosides, the urine isolate Bactrim, tigecycline, and then things that you would like to go to, like Colistin or maybe fosfomycin if it's in the urine, or ceftazidime Bactam. And I think the reality is if most of us call our lab and ask for these, the answer is, well, we don't routinely test those drugs, or we can't test those drugs at all. And I think this highlights one of the more difficult things that the lab is faced with these days, and that is the absence of tests for these newer drugs or even very old drugs that we haven't had to test previously. So to touch very briefly on Colistin as an example, it's obviously not a new drug, it's very old, but it was kind of left behind when the cephalosporins came out in the 1980s, early 90s, simply because of the toxicity issues. We're having to go back to Colistin, and unfortunately we just don't have the tools in the lab to test Colistin and polymyxin B. CLSI did update breakpoints for Acinetobacter and Pseudomonas aeruginosa, and you can see those here. But unfortunately, when we looked at the data for the Enterobacteriaceae, we simply did not have enough clinical data or PK/PD data to set a breakpoint. All we had was in vitro MIC data. And as a result, we came up, well, we didn't come up with it, but we applied a new concept that's sort of newer to antibacterial testing, which is this epidemiological cutoff value. And what this means is isolates with an MIC of less than or equal to 2 are considered to be wild type for Colistin or polymyxin B, and those that have MICs greater than or equal to 4 are considered not wild type. So what the heck does that mean? So the CLSI has started to assign these ECVs, again, epidemiological cutoff values, if there's just not enough data to really come up with a good breakpoint. And here's some examples of where we've done it. It's something I said that's rather new. I think the first one for bacteria was vancomycin and Propionibacterium acnes. As an aside, it's no longer P. acnes. It's now called Cudibacterium acnes, but that's the story for another day. And then we have azithromycin for Salmonella Shigella and Colistin for the Enterobacteriaceae, and then there's a whole slew of them for Candida and other molds like Aspergillus that are published. And so let me just explain really briefly with these two figures what the difference is between wild type and susceptible. And so this is the E. coli MIC distributions from the UCAST website. And so what this is, thousands of isolates that they've tested against cefazolin and cefataxime, and you wind up with this nice, bell-shaped curve of MICs. And so in purple, if we look at the cefazolin chart, every isolate with an MIC less than or equal to 1 is considered to be susceptible. And that's based on PK/PD data, on clinical outcome data, as well as this exact type of MIC distribution data. In contrast, isolates that have no resistance mechanism, so no mutations and no acquired genes, are considered wild type, and those are isolates with MICs below 8. And so what you can see is there's this collection of isolates here with MICs of 2, 4, and 8 that don't have any resistance mechanisms, but have MICs that are so high that you predict that you wouldn't be able to treat them with cefazolin for a systemic infection. In contrast, and this is the example that happens much more frequently, is for cefataxime, you can see wild type isolates, so again, no resistance mutations, no acquired resistance genes, have MICs of less than or equal to 0.25, whereas susceptible isolates have MICs of less than or equal to 1. And so again, here's a collection of isolates with MICs of 0.5 and 1, where they have some kind of low-level resistance, but you can overcome that with, typical dosing of cefataxime. And so, there's this disconnect, right? It's, the MIC susceptible intermediate resistant breakpoint predicts outcome. The epidemiological cutoff value predicts resistance mechanism, and those two things are not interchangeable. So this, of course, complicates things. The bottom line on it is we don't really know what an ECV means clinically, but I can tell you in practical terms, most of us, if you have an isolate with an MIC above the ECV for Colistin, there's probably some sort of mutation or acquired resistance gene. And in most cases, I think most of us would not want to use Colistin for therapy in those cases, even though maybe there's a chance it would be okay. But due to the toxicity issues around Colistin, I think we would avoid it. So at least to give you a sense, is this isolate normal? Is this like a normal MIC for this E. coli to Colistin, or is it not normal? But what it doesn't predict is treatment outcome. So on top of the fact that there's no clinical breakpoint for Colistin, there's no FDA-cleared tests for Colistin. So you can't get a Colistin DISC, you can't get a Colistin E-test, and in fact, those two methods just don't work. And there's no automated system in the United States that have Colistin on the system. And the reason for this is in order to get a system cleared through FDA, there needs to be an FDA breakpoint. And at present, there just isn't one, nor is there a sponsor for either Colistin or polymyxin B to propose a breakpoint to FDA. And so this has been a real big problem dealing with getting tests for these types of, drugs. But there is some good news. The 21st Century Cures Act that was passed last year is in effect at some point this week, and that takes breakpoints out of the drug label and allows FDA to recognize breakpoints set by other agencies like the CLSI. And so then the device manufacturer can get clearance for their tests with the breakpoints published by CLSI. And so there's a whole slew of examples. Acinetobacter is a great example where you can't get a breakpoint in the drug label because you just don't encounter enough Acinetobacter infections during clinical trials for new drugs. But CLSI has established breakpoints. So there is hope for the near future. But at present, things are not exactly where we'd like them. And even with these changes, I just want to point out that there's pretty big lags between the time a new drug is cleared, which is, time 0 on this graph, and when we get test systems cleared for that drug. And you can see the automated systems like the Vitech and the Microscan take a lot longer. And the reason for that is there's a lot of development that goes into developing a Vitech test for a drug, much more than a DISC. And so, this is in years we're talking about from the time a new drug is approved and when you get a test for it. And I think we're seeing that right now with drugs like cefazolin avibactam or ceftaroline tazo. I guarantee it'll be the same situation for Carbapenem, Carbapenem, and so forth. And the real difficulty with this is that, it's not like these drugs have predictable activity. There's a lot of literature out there, and here's just two examples of it, where a lot of patients have Cefazolin Avibactam resistant isolates, for example. And so, the bottom line is labs really do have to come up to test these drugs. At CLSI, we're working to promote adopting a DISC or other manual method to test these drugs, because the reality is I just don't think it's good patient care for the lab to not test just because there's no automated system for these. And so again, this is a way where you can work with your lab to help them understand the need for these tests. Okay. So moving on to sort of the last topic for the webinar, and this is to do with selective reporting. And selective reporting really is the decision process whereby you decide which drugs should be tested and which ones should be reported. And this should be a very, very collaborative activity. So not driven by just the microbiology lab, but the pharmacy, the P&T committee, ID physicians, infection control, stewardship program, other physician groups that have vested interest in some of these things really should be at the table for these discussions. The considerations, of course, include things that are obvious, like clinical efficacy, if it's on the formulary, what your antibiogram looks like, patient age, the body site of infection, as well as things that are a little bit more complicated sometimes, like the current consensus for what a first choice drug would be. But this selective reporting can also help minimize treatment errors, minimize emergence of resistance, cost, etc. And so let's take a look. CLSI has a definition for selective reporting, which is essentially you don't report everything you test. And this is important because labs test panels of antimicrobials that may or may not be appropriate for the given organism. A great example is most labs test a gram-negative panel, and it may have, a gram-positive panel, and they would use that same panel to test Enterococcus and Staph aureus, and maybe the Bactrim result's valuable for Staph aureus, but it's just not valuable for the Enterococcus. And so you can select this out as well to be doing cascade reporting, which is a strategy where you report results for secondary, more broad spectrum agents only if the organism is resistant to the primary agents within a particular drug class. So there's some pros and cons to this. I think that the advantages is you kind of get that out of sight, out of mind. You kind of lead people gently to the right treatment option. And it also, once you've set it up, there's minimal intervention once you've got it going. The disadvantage, of course, is the startup time. If you're not a hospital that currently does this, it can be quite difficult to come up with the best approach. There's also this risk, I know we struggle with this, but to cascade based on cost versus efficacy, and we don't want to fall into that bucket. And then, of course, we always have our clinicians who want all the information, not just some of it, and they'll figure it out on their own. And, in some cases that might be okay, but I think the reality is most of us don't always have a full sense of what is intrinsically resistant and what should be avoided and what shouldn't be. So really basic would be to avoid reporting drugs that CLSI has warning statements about. So this is the case we had at UCLA. It was a 2-year-old, previously healthy boy. He went to an outside of our UCLA network physician, and he had diarrhea. They did stool cultures. It was positive for salmonella. The lab just tested it on its routine gram-negative panel and reported it as susceptible to cefalexin. And so the patient received 10 days of cefalexin therapy, even though this drug, salmonella, is intrinsically resistant to. And so 2 weeks later, the health department did a follow-up stool culture on this little boy because he was going to daycare, still positive for salmonella. Shortly thereafter, he developed fevers, pain moving his leg, redness, swelling on his knee. They bring him to UCLA, and he had extensive osteomyelitis with abscess formation and fistula tract, which was essentially, a septic arthritis due to this salmonella. So they treated him with IND, 6 weeks of IV ceftriaxone. Unfortunately, he had adverse events to that drug. And when we did culture from the stool and the knee, the health department confirmed it was the exact same strain of salmonella that caused these two. Now, I'm not saying this is totally causal. It could have happened anyhow, but I think it's just a good example of, it was the wrong drug to start off with for this little boy. And so there's some, real basics that should not be ever done. And this is stuff where if you're seeing it happen, it's totally worthwhile reaching out to your lab and asking them to stop. I would say, too, the lab, sometimes there's things going on that we're just not so aware of. And so if you notice the lab is reporting, let's say ertapenem, and you don't want that reported, you think people should be using cefapime as the first line or whatever it might be, again, I think it's totally valid to phone the lab and raise those concerns, because we unfortunately are not always fully versed about what the issues are as the people in the stewardship program who are kind of boots on the ground and see what's happening. And then approaches to dealing with these intrinsic resistance or warning comments. Some labs would just report the drug as resistant, even if it wasn't tested. So for example, for an enterococcus, maybe you just report clindamycin resistant so that you get that positive feedback every time somebody looks at a result. They only ever see enterococcus as being resistant to clinda. Others just don't report that drug. And, there's pros and cons to both approaches, I think. Another basic that all labs should be dealing with and doing is, of course, reporting based on the anatomical location. So, warnings in the CLSI document include not reporting certain drugs on isolates from the central nervous system, or things like reporting daptomycin on respiratory tract isolates, which I think a lot of people are maybe not so familiar with, and, what not to report on urinary tract. Now, the CLSI recommendations don't always fully align with clinical guidelines. So here's a great example of it where, I had a lab call me and say, God, my ID docs just keep asking that we test and report chloramphenicol and a fluoroquinolone for the CSF isolates, but CLSI never do that. And so if you go to the Stanford Guide recommendations for pneumococcus, it is a treatment option. And so I think there needs to be a little discussion around these types of dilemmas or, discrepancies when they come up. All right, so let's talk about a final case where we can use selective reporting to mitigate therapeutic errors. And so this is a case of Staph aureus endocarditis in a 30-year-old intravenous drug user who presents with fever. Blood cultures grow Staph aureus. Here's my, stock Staph aureus picture. And on PTE, they saw large vegetations on her left mitral valve. And so this is the report that the lab issued, oxacillin resistant, gentamicin, MIC of 1, susceptible, vancomycin, MIC of 2, susceptible. And so the resident who was on service had heard about these MRSA with vancomycin MICs of 2 being associated with vancomycin treatment failures. And I'll be honest, there may have been a comment on the report to that regard. And so she placed the patient on gentamicin monotherapy. Right? And so, again, what we simply did is we quit reporting gentamicin on these Staph aureus and only reported oxacillin and vancomycin. And so you may ask yourself, well, why the heck was Romney's lab reporting gentamicin on these isolates to begin with? Well, this was one of those historical practices where, our ID docs really like to know the gentamicin susceptibility, because if they had a patient who was maybe not responding to vanco as they thought they should, they would like to know, add on gent or some other agent. And this is one of those things where the protocol just was never really looked at again, for years and years and years. So there was some nugget for why that was being done, but ultimately it was no longer appropriate. And so we made that change, and thankfully no more patients were treated with, aminoglycoside monotherapy for their endocarditis. So I think that's it, and I see that there are some questions, so I'll address those, but I want to thank you all for listening in. If you have any questions outside of what you want to put in the chat box, you can feel free to email me. I'm happy to respond to emails about this or any other micro type topic. So let me read some of the questions that we have. So one is, what is your experience in suppressed results being used for antibiogram development? Many facilities are now using vendor softwares for stewardship that put together antibiogram, but we find the antibiogram is built on limited data. And I think, so this is from Rosie, this is a true concern, and it's one of those other caveats to the antibiogram development. And it all depends on where the data is being pulled from. So at UCLA, we had our MIC data housed in the lab information system, and only what we reported went across the interface into the hospital information system. And the reason for that is we didn't want people to accidentally gain access to MICs that we hadn't reported. And labs don't report things for a lot of reasons. Maybe it's because we're confirming things, maybe because it didn't make any sense and we're checking for errors, maybe it's because it's intrinsically resistant, or maybe it's because it's part of the cascade and it shouldn't have been reported. And so if that type of scenario is true, if you build your antibiogram using the hospital information system data, it is going to be incomplete. The way you can address this is to go back to your lab and get the data directly from the source. Another approach is many labs use exclusively automated susceptibility test systems like the Vitek or the Microscan and so forth. And many of those systems have software that will help develop the antibiogram from that end as well. So that's another option. But I do think that when doing the antibiogram, it is good to have the lab involved, because the other thing that happens is if labs repeat susceptibility results to confirm resistance, and both of those results are in the system, you might be double dipping on your more resistant isolates. So the next question is from Pat, where they say they have a large national practice as an infection control consultant in skilled nursing homes. They're now required to obtain an antibiogram. For very small rural nursing homes, how relevant, useful are large regional antibiograms? I would say probably not very. It's sort of an annoying requirement because any skilled nursing facility I've worked with, they just don't have very many isolates. And they may or may not be culturing for the right reasons. And so a lot of, I think, the antibiogram reflects colonization, in particular the urine samples. And so I don't think it's all that helpful from a informing medical practice usage perspective. Where I do think it can be helpful is to kind of like a bit of awakening about how bad resistance can be in these facilities. I remember reviewing an antibiogram from one of our local SNFs, and they had 5% susceptibility to meropenem among their Klebsiella. Can you imagine? So I think that it is a pretty big wake-up call on how much resistance can kind of be lurking in these facilities. To that end, I can kind of speak about what you do if you just don't have enough data. And so it's legit to combine a couple of years of data. It's legit to work with your sister hospitals that maybe have a similar population to generate an antibiogram. Just be cognizant of the potential limitations to those approaches. So those are the questions. And then there's another question about sharing the slide deck. It's fine by me. If you'd like it, you can email me. I can send it to you. And I'm not sure if it'll be available on the web or not, but maybe Marnie can answer that question.
Absolutely. Dr. Humphries, thank you so much. We do have a couple other questions that I received. One of them relates to the new breakpoints for Cefazolin for Enterobacteriaceae. What advice do you give for an institution that's not adopted those breakpoints yet?
Well, for Cefazolin, I think it is kind of difficult because of the fact that most of the automated systems don't have dilutions that go low enough to even allow you to use them. So I guess it becomes more of a question about how often you're using Cefazolin, in your clinical practice to treat Enterobacteriaceae. And if it is a big issue and you're using it an awful lot and need those results, an option could be to talk with the lab about that need and maybe do things like diffusion for that Cefazolin result, or you know, you can consider something like a gradient diffusion strip, like e-test, keeping in mind that that is a manual process and it is kind of a big ask for the lab, so you want to make sure it's something that's really important to your clinical practice.
Another question related to, do you restrict or rank your antibiotic susceptibility reporting according to that antibiotic's propensity to drive Clostridium difficile infections? So almost like with antibiotic stewardship program, restricting antibiotics, you're almost restricting the reporting.
Yeah.
Does that make sense?
So you certainly, yeah, it does. I mean, so you certainly could. We did not, but if that is something you really want to focus on, then I'd say go for it. You know, you just need to make sure that you're not limiting things to the point where people get angry because they never get the results that they need. And there's different approaches to that. You know, one thing we did at UCLA for not antibiotics, well, we did do it for antibiotics, but also for tests, is we put dollar signs behind the antibiotic or behind the test. And at first I was really opposed to this because I thought, oh, jeepers, people are going to be just looking at dollar signs and not, you know, the right antibiotic. But what we found is a lot of people just had no idea how much some of these drugs cost. And so it was really eye-opening. And so I can imagine a very similar scenario for C. diff. You could develop a system, you know, kind of like the Yelp scoring, where it could be not dollar signs, but exclamation points or something along those lines that gave you a sense of that propensity to be associated with C. diff. Similarly, rather than cascading based on spectrum of activity, you could do it based on C. diff, propensity to cause C. diff. And so I think that would be a very interesting thing to do.
Dr. Humphries, unfortunately, we're out of time, so I'm going to have to close our webinar. As you mentioned, certainly our participants can contact you via the email there you'll see on the screen if they have further questions, and you'd be happy to help them, I'm sure, provide your guidance. So with the close, I just want to thank our participants for joining us and for their questions, and then remind you all that this webinar was recorded and will be available within the next day on our CIDRAP ASP YouTube channel website. So right there on our website, you'll be able to link and connect to a recorded version of the webinar. And Dr. Humphries, just want to thank you today for all your time and insights. You provided a lot of information for us.
Yeah, it's my pleasure. Thank you so much for having me.
Yeah, and just wish everyone a good day. Thank you.